The second talk will be about the PA catheter and measuring cardiac output. So first of all, let's talk about indications for the PA catheter. Older studies show no benefit and possible harm due to increased rate of complications. But those studies were done in mixed medical and surgical ICUs. CTICUs are a unique patient population where the PA catheter is very useful, and so sometimes not using a PA catheter in some of these CT surgery patients would be unethical, because it is so useful to help us titrate inotropes and to guide a resuscitation. In the 21st century, echocardiography has gotten so good that the main things that we use it for are for RV failure, continuous cardiac output measurements, and for pulmonary hypertension, especially so right-sided heart problems and for post-op CT surgery patients. So some anatomy of the PA catheter is there's kind of 5 different ports, 3 of which are true ports, 2 of which are just kind of plumbing. The first one is a distal port, which is that usually the yellow tracing on the telemetry screen, and that's the tip of the PA catheter for where the balloon is. The second one is a CVP port, which is about 30 centimeters distal from the tip. The third is the VIP, or the injectable port, and that's about 31 centimeters from the tip. That's where all the drips go. And then the fourth and the fifth are for the balloon and for the wiring. So let's talk about floating the swan next. And for that, first of all, swans have to go through an introducer. So you have to prep patient, drape patient, put the introducer in, flush all the ports, check the balloon, and then you connect the distal port to the PA transducer. And then when you're ready to go, put like the plastic swan covering on first before you put it through the introducer. You're gonna put it about between 20 and 30 centimeters in, zero the distal port, and then inflate the balloon, and you're ready to float. So you're gonna advance the PA catheter into the heart, through the right atrium, through the right ventricle, and through the RVOT, and finally into the pulmonary artery, and eventually it's going to wedge into a distal PA branch. And you record the wedge pressure and the catheter length, pull it back 5 to 10 centimeters so that it's in either the right or the left main PA, and then get a chest X-ray to confirm its position. Some troubleshooting with placing swans, and I kind of, these are all things that I've kind of learned from experience, both good and bad. If you want to look up the waveforms, you can always do that, but there's a lot of really good resources for that already. So I kind of focus on these kind of tips and tricks that I've learned from placing countless of these things. And the first is to insert the swan with the tip pointing to the left shoulder, because it's going to match the anatomy of the heart better. The next is placing the patient from right side up, facilitates the transition into the RVOT, because when you put a patient right side up, you will the balloon in the PA catheter is going to float anteriorly, and the RVOT is also an anterior structure. So by putting the patient right side up, you kind of use physics to your advantage, and the RVOT and the balloon are going to meet. The third thing that I do is I try to be fast. So, and that's for 2 different reasons. The first, if you let the swan warm up to body temperature, it becomes too pliable, and it becomes more likely to coil in the right ventricle and not pass through the RVOT. So generally, you either want to be floating the catheter or you want to be pulling it out of the patient. So don't just leave it in the patient to get warm and flexible, because it's going to make it harder to float. The second reason why you want to be fast is that if you leave the swan on the RVOT, it's going to cause a lot of ventricular arrhythmias. So causing non-sustained VTAC is fine. Causing sustained VTAC is not fine. So you really want to get through the RVOT as fast as you safely can. Some signs that you're in the correct place are one is arrhythmias, right? If you're having arrhythmias, you're releasing the heart. The second thing is diastolic step up, or the appearance of the dicrotic notch. That means that you're past the pulmonary valve. And again, I'm not going to go through the different waveforms. You can use different resources for that. There's lots on there, and even on a quick Google search. The other thing that I also found is if you find the swan having a lot of resistance at about 60 centimeters, it means that you're probably wedging. Sometimes you don't get a very nice wedge waveform in certain patients, and I can't tell you why, but just know that sometimes it's not like a perfect wedge waveform. But if you're getting resistance at 60 centimeters, you can be reasonably sure that you're in. Deflate the balloon, pull it back, and get a chest X-ray to confirm. The last thing that I want to go over is just there's no such thing as an emergency swan. So don't think that, please don't try to place a swan like 6 times. I've seen it. It's not good it's dangerous for the patients. You usually lose sterility, and generally if you don't get it the first, I think, 3, if you don't get it on tries 1, 2, or 3, the odds of you getting it on tries 5 or 4, 5, 6 and up decreases. So if you're having trouble, either ask for help, or there are certain patients who just swans cannot be placed at the bedside for anatomic reasons. And once in a while, I ran into a grand total of 2 in my life, and sometimes cardiology has to take him to the cath lab. But there is no such thing as an emergency swan. So please don't injure patients because you want to place a Swan-Ganz catheter. Then next, we are going to go to measuring cardiac output with the swan. And the first thing that we're going to talk about is the mixed venous oxygen saturation. And again, that's the percentage of the O2 bound to hemoglobin in the right heart. When we talk about mixed venous, you generally have 2 different kinds, and they're clinically indistinguishable, but I think for test purposes and for a completeness, I just put them both in there. The first is SVO2, which refers to a mixed venous drawn from the right atrium, and the second is SCVO2, which corresponds to a mixed venous drawn from the pulmonary artery. Unless the heart is super ischemic, they're going to be pretty much the same. So in the cardiac ICU, they're generally clinically treated as the same. In the CCU and in the non-surgical cardiology world, it might be different, but for us, they're pretty much the same. A normal value, again, is between 50 and 70%. If you have an SVO2, or I should say, if you have a mixed venous greater than 70%, what that means is that there was decreased circulation time, and that hemoglobin didn't have a chance to drop off enough oxygen, and that generally correlates to an increased cardiac output or hyperdynamic circulation. And if the SVO or if the mixed venous is less than 50%, it generally correlates to an increased circulation time, and that means that hemoglobin had too much time to drop off the oxygen, which would mean patient has a decreased cardiac output. And this kind of very simplistic rule assumes that O2 supply and demand are constant. So any pathologies that alter this is going to alter mixed venous. So you have to really interpret it in the context of the whole patient and don't just take the numbers at face value. The main clinical use of mixed venous is it's a quick, easy, cheap way to screen for worsening cardiac output. So you can collect it from a PA catheter, from a right IJ, CVC, or from a PIC. But it does have a 10% error range, so just know that the trend is more important than any singular value. But it is a very quick screen. The test comes back in 15 minutes. So if you think something, you can. It's a very cheap, easy test. It's very valuable to know if you're going in the right direction or not. The last two things we're going to talk about are cardiac index and the CCO monitor. So cardiac index we talked about in the previous lecture. It can be calculated by thermodilution or by the Fick equation. These are things that you can read about in other sources. What you essentially need to know is that this is what really the PA catheter is super useful for post-op, is that you can calibrate it with hemoglobin and with SVO2s, and it can tell you how the cardiac index changes over time. Then this is shown on the CCO monitor, which is a monitor attached to the Swan-Ganz catheter, and it generally will display a mixed venous cardiac output and cardiac index. You can also use it to measure SVR and PVR, and I put the calculation of it below. You don't need to memorize this. I just put it in here kind of as just to prove that the PA catheter, being able to calculate the cardiac output and the cardiac index, is incredibly valuable. So sometimes these things are placed in patients that seem, quote, overkill. But what I found is being able to always know what the cardiac index is a huge advantage clinically when these patients have post-op complications. And at the end here, I just listed different things that you can measure from the PA catheter. It's very, very useful in cardiac surgical critical care. So just knowing how to place them and knowing how to interpret them is going to make your life a lot easier, and it's going to allow you to communicate with the CT surgeons and the cardiologists more efficiently.